stand here and present this data on behalf of the task force regarding type, duration and management of DAPT in surgical patients. I was representing the European Association for Cardiothoracic Surgery at in this task force. These are my declarations of interest. So first, about cardiac surgery. There are in total 8 recommendations about cardiac surgery patients in this update. The first one here is the recommendation that a heart team should estimate the individual bleeding and ischemic risk and guide the timing of CABG as well as the antithrombotic management. I think this is one of the more important recommendations. This is not one-size-fits-all treatment. We need to consider the patient's status, the coronary anatomy, before we decide how we should continue, if we should continue or stop the dual antiplatelet treatment before surgery, and when we should resume the therapy afterwards. The following 7 recommendations I will speak a little more about. So this is the recommendation about aspirin. In patients on aspirin who need to undergo non-emergent cardiac surgery, it is recommended to continue aspirin at a low daily regimen throughout the perioperative period. This is mainly based on the meta-analysis of Hastings published 2015. There was a reduction in the perioperative myocardial infarction rate of the CABG in patients that were maintained on aspirin. Again, we need to have, of course, an individual assessment, and in patients with high bleeding risk and in patients refusing blood transfusion, aspirin may be stopped before surgery. This is the recommendation about discontinuation of the P2Y12 inhibitor before cardiac surgery, where we now recommend postponing surgery for at least 3 days after discontinuation of ticagrelor, at least 5 days after clopidogrel, and at least 7 days after prasugrel. This is a new recommendation. In the old guidelines, it was recommended 5 days both for ticagrelor and for clopidogrel. This is mainly based on a large observational study from the Sweetheart Registry, where the incidence of bleeding complications in ticagrelor patients who stopped the treatment 3 to 5 days before surgery was similar to the ones who stopped it more than 5 days before surgery. For clopidogrel, you can see there's a gradual decrease in the incidence of bleeding complication, and it's lower at more than 5 days compared to 3 to 5 days. This study is further supported now from 2 small studies, one from Netherlands showing that there was no difference in the incidence of major bleeding with ticagrelor stopped 72 to 120 hours before surgery compared to aspirin only. And this more recent observational prospective study shows the same. This is a slide from the update, where it's again shown that prasugrel should be stopped 7 days before surgery, clopidogrel 5 days, and ticagrelor 3 days before surgery, at least 3 days before surgery. This shows also that we should resume the therapy after surgery, and the exact time point when it should be resumed remains unclear. I'm coming back to that in a little while. These are the recommendations about resumption of dual antiplatelet therapy after cardiac surgery. It says that in patients treated with dual antiplatelet therapy after coronary stent implantation, it's recommended to resume the P2Y12 inhibitor postoperatively as soon as deemed safe and continue the treatment until the recommended duration of therapy is completed. It's a class 1 level of evidence C recommendation. It's also recommended that in patients with acute coronary syndrome not requiring long-term oral anticoagulation therapy, we should restart the therapy as soon as deemed safe and continue up to 12 months. Again, class 1 level of C recommendation. And in fact, when it comes to resumption of dual antiplatelet therapy after cardiac surgery, there are no dedicated studies. The only thing we have is data based on meta-analysis of small randomized trials, CABG sub-studies in the larger acute coronary trials and observational studies. The optimal time point to resume DAPT after CABG is not defined, but 24 to 96 hours after CABG seems reasonable. Shorter time in patients with recent implantation of stents, and maybe a little longer in more stable patients. There is a concern over the high incidence of postoperative atrial fibrillation in these patients, and it might end up with a situation where triple therapy is discussed. We should continue the DAPT until the recommended duration of therapy is completed. And dual antiplatelet therapy after CABG in patients with stable coronary artery disease and no recent stent implantation is not recommended unless concomitant indications exist. When it comes to the length of the treatment period, it's the same as we have previously discussed in patients undergoing PCI. So to summarize the recommendation in patients undergoing acute coronary syndrome undergoing bypass grafting, in patients with high bleeding risk, it's recommended 6 months of dual antiplatelet therapy to a level C recommendation, and in patients with normal bleeding risk, 12 months DAPT, a class 1C recommendation, which also may be prolonged according to the same examples as we heard before. We have also a recommendation about platelet function testing. It may be considered to guide decisions on timing of cardiac surgery in patients who have recently received P2Y12 inhibitors. So this is in contrast with the general recommendation of not using platelet function tests to guide treatment in patients that are on dual antiplatelet therapy. This is based on several studies now showing a correlation, or at least an association, between the platelet aggregability before surgery versus the probability of severe bleeding in patients treated with aspirin and ticagrelor. This is one example. And there's also a randomized trial showing that there were shorter waiting times when platelet function testing was applied on CABG patients treated preoperatively with aspirin and clopidogrel. So a few words about non-cardiac surgery. Most of the recommendations are similar to the ones that we have for cardiac surgery, but there are also 1 or 2 exceptions. There's in total 7 recommendations. This is the difference is that we really should try to avoid discontinuing the P2Y12 inhibitor the first month after non-cardiac surgery. The recommendation reads that this should not be discontinued within the first month. There's also a recommendation that after coronary stent implantation, elective surgery requiring discontinuation of the P2Y12 inhibitor should be considered after 1 month, irrespective of the stent type, if aspirin can be maintained throughout the perioperative period, a 2A level of B recommendation. This is based on 2 large observational studies. This first one is from Denmark, where over 4,300 patients undergoing non-cardiac surgery with previous stent implantation was compared, and there was a much higher incidence of complications, in this case all-cause mortality, if it was less than 1 month after stent implantation. Further support comes from a large American study from the Veterans Administration with over 26,000 patients. So this is how it's summarized in the update, where there's a class 3B recommendation for not discontinuing dual antiplatelet therapy during the first month after coronary implantation. From 1 to 6 months is a class 2A in patients with low risk for ischemic events, and a 2B recommendation in high risk events. And after 6 months, the treatment can be stopped. So thank you for your attention.
Thank you very much, Anders, for this nice and comprehensive presentation. If there is a question there, feel free.
Yeah, this is Sergio Leonardi. I have two short questions. First, you know there are two dosages of ticagrelor now, 90 milligram BAD and 60 milligram. Do the 3-day recommendation apply to both dosage? And the second question is, would you consider bridging with intravenous antiplatelet agent for high-risk surgery?
Regarding the first question, whether 90 milligrams ticagrelor or 60 milligrams ticagrelor should be stopped at the same period, we don't have any data. I mean, the 60 milligram dose is only recommended for stable persons after post-MI. So all ACS patients today, to the best of my knowledge, are treated with 90 milligrams, and all the data we have come from that. The second question was whether we should bridge patients at high risk, and I think that's reasonable in selected patients, where we can use either cangrelor or a GP2B3A agent.